coming to us remotely. Dr. Truman Milling, TJ Milling, is an associate professor in the Departments of Neurology and Surgery and Perioperative Care at the Dell Medical School at the University of Texas in Austin and an attending physician at the Dell Seton Medical Center at UT. He's also Research Division Director of the Seton Dell Medical School Stroke Institute, serves as the Perioperative Hemostasis Committee for the Society of Critical Care Medicine, and is a member of the American College of Emergency Physicians and the Society of Academic Emergency Medicine. He has extensive research experience and has received funding from the NHLBI, NINDS, NIH, and the Lone Star Stroke Network. And he's going to be speaking to us today about restarting anticoagulation after intracranial hemorrhage. So we hope the technology will work. So please join me in welcoming Dr. Milling.
Hi. So sorry I couldn't be with you this morning. I've had the pleasure of working with Center and a group of trauma clinicians from across the country, and sort of getting at these questions at this conference has been so helpful at crystallizing. It really is, as Dr. Gertz said, it's about balancing bleeding and thrombosis, and it's always a two-way street. And too often we get a little too focused on bleeding because, let's face it, we're programmed to see red, bleeding. It gets our attention. It's the thing that got them into the emergency department. And it's easy to focus less on thrombosis, which is sort of quiet and surreptitious, but just as deadly down the road. So I came at these questions from having roles and writing papers around anticoagulant reversal and looking at the safety side of that, right? So it's the same deal. In the acute bleeding scenario on an anticoagulated patient, obviously the bleeding takes precedence and we need to turn off the blood thinner. But of course, these patients were on a blood thinner for a reason. And what I noticed in writing the safety papers was following these patients out to 30 days, which is something that gets lost when you do retrospective research or single center research. We tend to only be able to follow them for the period they're in the hospital. And a lot of these patients go home in a week and we really don't know what happens to them after that necessarily. They go back into the primary care world. Well, in these reversal trials, we followed them meticulously for 30 to 45 days. And guess what? Very few of them get restarted on their anticoagulant. And 1 in 10 have a thrombotic event. And those events after that hyperacute period are eminently preventable by anticoagulation in the vast majority of patients. And I mean, if you look at, there's a biological basis for hyperacute restarting of anticoagulation, right? So the clot forms in the first 24 hours, and anticoagulants don't break fibrin bonds. They simply prevent the deposition of new fibrin. So I know we would all be nervous about starting full anticoagulation on day one, but there's a biological underpinning for that. But you have to meet equipoise where it is to do a clinical trial. So to find a patient population that was homogeneous enough to do a randomized trial of restarting or restart timing was difficult in across all bleeding, definitely. I mean, GI bleeding, hemorrhagic stroke, traumatic intracranial hemorrhage, and other traumatic major bleeding. But even within trauma, these are very heterogeneous populations. And even within TBI, the youngster who gets on the wrong end of a baseball bat, or the middle-aged person in a car wreck. But in backing into this and looking at who the anticoagulated patients are, we realize there really is a very homogeneous group. Nothing's ever going to have a perfect bright line around it, but pretty close. When you look at anticoagulated patients with traumatic intracranial hemorrhage, 95% are elderly trip and fall. They have a pretty reliable profile of comorbidities, a lot of them, because they're elderly and they're on an anticoagulant for a reason, either stroke or VTE. Most of them are over 55. So, and of course, spontaneous hemorrhagic stroke also is a reasonably homogeneous population, but the neurologists have been all over those questions. And there's quite a few trials in spontaneous intracerebral hemorrhage on the question of restart. And there, the first question they're asking is yes or no. Should we or shouldn't we use the anticoagulants versus nothing or antiplatelets? I do want to make the case here that while it's tempting because the data is coming out and there's going to be quite a bit more on restarting in spontaneous intracerebral hemorrhage, that looking at that data is sort of like, from a trauma clinician standpoint, is sort of like looking for your keys under the streetlight when you dropped them a half block away, right? There's lots of light there, but that's not where those patients are. Spontaneous intracerebral hemorrhage is almost always caused by an underlying vessel abnormality, and whether that's cerebral amyloid angiopathy or microvascular injury from chronic hypertension. So where there is one abnormality, there are probably others, and I'm sure you've seen those very scary MRIs of people with CAA where they've got these microbleeds all over the brain. So that it's a very different question in those patients because their baseline risk is still there after the first bleed. There's another place that has a high likelihood of bleeding. So it's reasonable in hemorrhagic stroke to ask the question, should we or shouldn't we? But in traumatic intracranial hemorrhage, it's generally an isolated event. And we can talk about fall risk, which tends to get overblown, which of course is a baseline risk of another bleed if they fall and hit their head again. And that there's a subgroup of patients with high fall risk that perhaps shouldn't be restarted, but they're in significant minority. In fact, there was a nice paper in Archives of Internal Medicine. It's been a long time ago now. It's like right around the turn of the century, that suggested in a Markov analysis that you'd have to fall almost daily for the fall risk to offset the stroke prevention risk of anticoagulation. Of course, that's in the warfarin era, and now almost everyone's on DOACs. But I think to understand the clinical trial that we're working on with Center, you have to believe, and I think there's enough evidence of that, and you'll see that here, that in the majority of these elderly isolated head injury patients on pre-injury anticoagulation, that the question is not whether to restart anticoagulation, it's when. And this sort of underpins it. This was Peter Nielsen's paper with Greg Lipp that just showed the difference. I think before this paper, it was the whole streetlight phenomenon was even more widespread, that somehow if we have data in situ, we can just extrapolate that to traumatic. Well, this paper made a really good point. It's based on Danish registries that the rebleeding risk difference is huge. I mean, this is obviously not a randomized trial, so there's going to be some bias, but the same bias is there for the hemorrhagic stroke as the traumatic cases, and there's this huge difference in recurrent bleeding in the traumatic versus the spontaneous cases. And I think this reflects that underlying difference in mechanism of disease in these two entities, which are distinct and should be studied separately. Interesting also, it's not as wide, but there was actually more stroke, in addition to decreased bleeding, there was better stroke protection from anticoagulation in these traumatic patients as well. This is not ideal evidence, and I think I've heard the previous speakers making the point that we need more evidence, and I totally agree with that. So on the question of what's the benefit, what's the potential net benefit of restarting? Well, there's lots of retrospective evidence, and we can get a sense, and also taking the traumatic patients out of the reversal trials, we can get a couple hundred patients and get a sense of what the net clinical benefit is likely to be. So restarting, is it to thrombotic events prevented is about 1 to 10 if you treat them all equally. But of course, all bleeds and thrombotic events are not equal, and we have to have some way of weighting them. We can look at the worst case scenario, that every rebleed you caused was a severe recurrent intracranial hemorrhage, and every thrombosis prevented was a DVT. Even weighting it that way, which is unrealistic, of course, the truth is somewhere in between these two. You still get a 1 to 2 risk benefit and a net clinical benefit that favors restarting anticoagulation in these patients. And this is just the way these are weighted, by the way, is patient utility scores. So the patient does something like a standard gamble or time trade-off, and you can get a sense of what this disease state, as described to them, weighs relative to death. And then if you have both diseases relative to death, you can rate them relative to each other, which answered a big mysterious question that I had when I first started doing this. It's like, how many DVTs equals an intracranial hemorrhage? And there's a way to answer that, and it's about 5 in terms of disability. I wanted to talk briefly about subdurals because they're kind of the odd man here. I mean, if you look at all subdurals, they tend to behave at the small end like the rest of traumatic, but at the high end, they act more like spontaneous intracranial hemorrhage or intracerebral hemorrhage, which is why one of the restart trials, the biggest one, Enrich AF, in spontaneous, includes subdurals. You look back at all the numerous case series, some of them are over 800 cases, you can risk stratify subdurals. So you can sort of cut this oval in the middle in half so that you can include some subdurals in a restart timing trial, while allowing that some of the larger ones, probably the question is more yes, no, as opposed to when right now. Larger ones tend to recur, and we see them come back to the ER quite a bit. But the small ones, and from the existing literature, small meaning less than 8 millimeters without midline shift, don't have that tendency to recur. So when we selected patients for a restart timing trial, and again, this is full oral anticoagulation, not just VTE prophylaxis, we include the very small subdurals in that group, and Enrich AF may answer the question for the larger ones. Although it will be a subgroup and underpowered, and I think we're already designing a trial specifically for subdurals if the pilot data tends to indicate uncertainty, then it may just be a subdural yes/no trial. If the pilot data from Enrich AF indicates a benefit in that subgroup, then it would be a timing trial. So the central hypothesis for our trial is that there is a best time after traumatic intracranial hemorrhage that optimizes the composite outcome of bleeding and thrombosis, recognizing that both sides of that coin matter, and net clinical benefit relies on understanding the bleeding risk and the severity of those bleeds, and the thrombotic risk and the severity of that thrombosis. And it's probably not one-to-one. We probably don't have it, and if it was, then there would be no point, right? If for every day without anticoagulation, you increase the thrombotic risk by the same amount as you decrease the bleed risk, there would be no rationale for proceeding. But it really looks more like this, right? So the bleeding risk drops very quickly. There were some good papers by Hollyrook that suggested it's really the first 72 hours, and hematoma expansion thereafter is vanishingly rare and or extremely rare. And then by a week, of course, it's vanishingly rare. And these are assuming patients that have a stable CT over some 24-hour period and then are restarted and have a rebleeding risk thereafter. So if it really does follow this, then the net clinical benefit, I clicked the wrong thing, would be the purple line there, a combination of the bleeding and thrombotic risk. And there would be a sweet spot. There'd be a nadir in the combined risk that would represent the best time to restart. And we don't know when that is. It could be over later. It could be over earlier. I suspect it's earlier, given what we know about the biology of clots and hemostasis, that earlier is probably better, and that the bleeding risk is small, but the potential for thrombosis reduction is very large. And I've mapped out across all the reversal trials when the thrombosis happens, and you get to 3% in the first week, perhaps not preventable because the patient's still in a hyperacute bleeding scenario. But maybe there's an additional trial after this one that would examine restarting in very early periods. But it's not where the equipoise is now. But the other 6% or so of bleeds, particularly in the trauma patients, which actually have a higher background, or it's from a heterogeneous group of data sources, but appear to have a higher thrombotic risk than the non-traumatic presentations of major bleeding. Your 6 or 7% that just stretches out over the 7 to 28 day period, and probably quite a bit beyond that. But the trials only followed people that long. At most in the Indexinet trial, 25% were restarted. A handful restarted in Kcentra, and even a similar number is Indexinet and idarucizumab trial. And as you might expect, there were quite a few thrombotic events in patients. a lot more in the patients that were not restarted than those who were restarted. In fact, in the Andexanet population, no thrombotic events occurred in patients who were restarted. And we did a analysis of that in thrombosis and hemostasis. Just noting that fact. And there's another paper we're about to publish on the full data set of 479 patients, 2/3 of which are ICH, about half of those ICH being traumatic, that shows, yet again, even in the larger sample, if you restart full oral anticoagulation, you don't get any thrombotic events out to 30 days. But again, only about 25% of these patients are restarted in 30 days. And looking at our own data sets from our center, when you follow these patients out even further, some are never restarted and they just represent with a stroke. I actually had that case last week where a patient had a fall and hit her head, had a tiny subarachnoid bleed, decision made to hold anticoagulation, discharged on hospital day 3, came back 2.5 weeks later with a large MCA stroke for untreated AFib. So this is a great example. Now, they said she was had fallen 3 times prior to that presentation. So perhaps the risk benefit wasn't accurately assessed. But now she's a major disability from her MCA stroke. So we think if we randomize people to restart at 1, 2, and 4 weeks post-injury, this being traumatic intracranial hemorrhage with a stable head CT, and subdurals less than 8 millimeters, that the endpoint will look something like this. The week 1 will have the lowest thrombotic event rate, but some incremental increase in bleeding, probably less than 1%. Whereas week 2 will have less bleeding, but more thrombosis. And of course, week 4 would have the most thrombosis and probably the least bleeding. Then you have to decide what bleeding and what thrombosis, right? So we have to make some decisions about what counts in terms of what's severe enough so that we don't, we can also, and we are doing standard gambles to get a sense of patient utility for these endpoints and then do a weighted analysis. But in our primary endpoint, it's more, each event is sort of counted as the same. So you have to remove minor bleeding, remove even clinically relevant non-major bleeding. And for us, we're using the Bleeding Academic Research Consortium scale to define what constitutes a major bleeding episode. But then on the thrombosis side, you have to think about, in trauma, DVT matters a lot, right? So we didn't want to exclude it in the primary analysis, but we have to acknowledge that the mortality near term, at least, is quite a bit lower than the other presentations. So we do a primary analysis with DVT and the composite of bleeding and thrombosis, and then a second analysis sort of removing DVT and focusing on the higher morbidity, mortality, thrombotic events. So the trial restart traumatic intracranial hemorrhage is time as a dose. Essentially, it's a dose response study, right? So if we get a certain amount of time produces a response in thrombotic events and bleeding, 2 sort of opposing monotonic trends. We use response adaptive randomization, which is becoming much more common. There's still purists who hold on to fixed trials. I don't disagree that it can be cleaner, but response adaptive randomization has 2 major benefits. So it's more ethical because as the trial progresses, more patients are randomized to better performing groups. And this is more ethical and can certainly be something to highlight in the consent decision with the patients. And it has the potential to stop early. If the differences are larger, you have these frequent interim analyses that can lead you to, in the trial, once you achieve a certain preordained level of significance. And as you can see, the interims are quite frequent. They're 300, 400, 500, 600, and so on out to 1,100. We expect about a 10% dropout, which in trauma, you might think that number is a bit optimistic. However, because we've identified this sort of special population, and not a small one, 100,000 or so patients a year, who are elderly or on anticoagulants and have a traumatic intracranial hemorrhage. These are older patients established in their community and have somebody prescribing their anticoagulant. So we expect them not to be as difficult to find in follow-up. And you can see this as an example, a simulation of this trial shows that 606 of our 1,100 patients will go into the better performing group, which is twice as many as would in a fixed trial. This is a trial schematic from our paper in Journal of Neurotrauma. Essentially gives you an idea of how things break out. So they present to the hospital. The trauma team has 6 days to decide if it's an appropriate patient for randomization. And then they are, about half of these patients will go home by day 4, by the way, and the other 25% or so will go home by day 7. So essentially we'll be calling in or sending the patient with a prescription for their restart day and working with primary care to make sure that's continued if they happen to get a follow-up appointment in that 30-day period, which I suspect is the exception rather than the rule in the American healthcare system. But you always want to make sure that you collaborate with their primary care providers. So there's 2 places where this trial can adapt as a sort of smart trial. The randomization itself adapts as one group or another starts performing better. And then because what all of our event rate estimates are from the anticoagulant reversal trials, by and large, if we're wrong and the event rates are low, a trial could fail for futility. So we've added a feature that adapts the CHADS-VASc score, which actually so we're including both patients who have an indication for AFib and for VTE. But CHADS-VASc actually does predict thrombosis risk in VTE patients as well as the patients for whom it was developed, which is, of course, AFib, potential stroke patients. So we can adapt. That's a lever that we can adapt up from starting at 3 and moving upward to enrich the sample for thrombotic events and potentially keep the trial from failing for futility if the event rates were much lower than we suspected. That said, I think the event rates are going to be at or higher than our 9% estimate in this patient population. The other question in a clinical trial is, are we being too broad, right? We think we have a pretty well-defined patient population with similar risk and similar benefit, but at that first interim, we wanted to recognize that there may be patients with a higher rebleeding risk or a higher frailty fall risk or a lower thrombotic risk. So we have a pre-planned analysis for outlier groups that might then be added as exclusion criteria. And we have funding for the first 200 patients from CSL Behring and are about to launch the Vanguard through the Geriatric Trauma Research Network and Center and collect the first randomized data on this important question. The main grant is funded through NHLBI. The DSMB can approve to include these patients, so we'll have a head start and only need 900 more. And this is just the typical course of a patient in this trial. We know most of them will go home and we'll have to do sort of outpatient Zoom and telephone monitoring to make sure that they're compliant with their drug and also to check for endpoint events such as stroke, MI, or VTE. And we want to be cognizant that we are plugged into their primary care network and hand off all the information that's relevant to their primary care provider at the end of the study in 60 days. We've already talked about most of the inclusion and exclusion criteria, and I think I'm coming up on time. So, but essentially most traumatic intracranial hemorrhage patients on pre-injury anticoagulation in which the clinician intends to restart a DOAC, warfarin creates problems with timing trials because the onset is slow and in AFib, bridging with Lovenox is not standard. So, and the vast majority of people are indeed on DOACs these days. So we didn't want to try to answer the warfarin and DOAC question together. And just exclusion wise, we're excluding the large subdurals and anybody who has an indication for warfarin, and we don't want people on antiplatelets and anticoagulants. It's a pretty small group, but don't want it to confound our bleeding risk data. And that's it. I appreciate your time this morning, and I'll take any questions.
The risk of recurrent bleeding in trauma patients who have or don't have evacuation of their hematoma, does that alter the patient's risk of recurrence? Obviously, there's size and other issues, but the impression I got from my neurosurgery colleagues that if patients have the subdural drained, that the risk of recurrence was less than if it was left in situ. But I don't know if that's true. What's your opinion on that?
Yeah, I mean, we kind of dodge that question because we exclude any subdurals that are greater than 8 millimeters. So that's probably all of the operative subdurals. It'd be an interesting question, and it's hard to parse out from the literature when these subdurals present the risk of recurrence in operative versus non-operative intervention. I think the neurosurgeons believe they're pretty low risk after their intervention. I don't think we would want to include them in this trial. Just we're trying to answer the big question for most patients and then sort of answer these individual questions in a specific subdural trial, because especially the larger subdurals, they just behave so differently than the vast majority of these small subarachnoid subdural contusion patients that represent 90% of what comes into the ED.
Thanks so much, DJ.
Thank you.